Good afternoon, everyone. I'm Jonathan Agri. I'm the Associate Vice President overseeing development and alumni relations for the George Washington University Health and Medicine Group. We're delighted to have you join us for this exclusive look today into GW's COVID response. Over the next hour, we'll hear from clinicians, faculty, and grateful patients, offering a firsthand look at their role in GW's response to the COVID-19 pandemic. Now I'd like to introduce Dr. Lynn Goldman, the Michael and Lori Milken Dean of the Milken Institute School of Public Health and Professor of Environmental and Occupational Health, and she'll welcome our guests. Dean Goldman.
Thank you so much, and thanks to all who are joining us this afternoon. No, I'm not alone in saying I look forward to a return to in-person gatherings, and with the recent news about the positive vaccine trials, maybe that day will be here sooner rather than later. Today, we will highlight some of the important work being accomplished at GW in response to the COVID-19 pandemic. The ingenuity, scientific capacity, expertise, resilience, and care demonstrated by our community during this time is nothing short of incredible. The pandemic is really several pandemics at once, or what we would call a syndemic. The COVID-19 virus, increased unemployment and poverty globally, racism and racism's impacts on health, obesity and chronic disease, a disordered healthcare system that is not providing either preventive care or equitable coverage, and a planet that is suffering from climate change-related health threats like storms, heat waves, fires, and flooding, devastating shifts in disease vectors and pathogens, and disruptions in availability of water and even agriculture. This is quite a legacy for the next generation, and that is why your contributions, each and every one of you, as teachers, mentors, potential employers, and especially as donors who provide desperately needed financial assistance, is so important. In all ways, we rely on our strong collaborations across public health, nursing, medicine, and health sciences, the MFA, and others. For me, a highlight of the year was when Barbara Bass joined GW. She is a wonderful partner, and GW is lucky to have her. There have been many highlights of our coronavirus response. The partnership between Stacy DiLorenzo in Public Health and Frank Sesno of the School of Media and Public Affairs has provided critically important information to the public via our Healthy You podcast. Our alumni have contributed, including Dr. Juan Reyes, one of today's speakers, who is alum of both the School of Public Health and the School of Medicine and Health Sciences. Our amazing faculty, David Michaels, the former head of OSHA, who has worked tirelessly during this time to lead the change to provide stronger protections for healthcare and other workers. Dr. Eugene Migliaccio, who ran all of occupational health for the federal government, who has worked with the MFA and others to organize GW's occupational health efforts. But I'm especially proud of 7 women on the SPH faculty who have emerged as leaders during this time. Dr. Manya Magnus, an epidemiologist and PI of our proposed NIAID AIDS clinical trials unit, helped to assure GW's participation in the Moderna trial as a result of many years of effort to build the capacity to recruit patients from historically underserved populations. Dr. Cindy Liu, a public health infectious disease researcher, featured in GW Today for her role in designing a highly accurate COVID-19 test, securing FDA authorization, and building a laboratory that's providing consistent, accurate results. Dr. Polly Pittman, director of our Fitzhugh-Mullen Institute for Health Workforce Equity, quickly developed a contact tracing workforce estimator and a state hospital workforce deficit estimator, as well as national seminars that address health workforce inequities, all of which have been invaluable resources. Drs. Amita Vias and Karen McDonald, professors in prevention and community health, who have directed our public health COVID investigation operations and regularly serve as advisors to both to our universities and the local government. Dr. Melissa Perry, professor and chair of environmental and occupational health, who built on her research in injury and infectious disease prevention in the meat cutting industry to advise governments and others about preventing coronavirus transmission among those workers. Last but not least, Dr. Amanda Castell, HIV epidemiologist and PI of the DC AIDS cohort, who I'm delighted to say as a part of today's panel. She has served as GW's coronavirus epidemiologist and is an invaluable resource to the Department of Health in DC. These 7 leaders and their teams are just amazing. Public health and nursing and medicine work together to organize 235 volunteers who assisted our community with pandemic response efforts at 8 sites across the DC region. All across our community, people have consistently and passionately put safety and care above all else. Thank you for being among them by donating philanthropically to support our research and our students. This is our hope for the future. In a time when the world is facing so much anguish and uncertainty, we very much appreciate your selfless support of our university. Thank you so much for being with us today.
Thank you, Dean Goldman, our wonderful dean of our Milken Institute School of Public Health. And thank you to your wonderful dog. It's always great to see dogs in the background and get a sense of who we are as people outside of the workplace. Now I want to introduce Dean Barbara Bass. She is the Vice President for Health Affairs, the Dean of the George Washington School of Medicine and Health Sciences, Professor of Surgery, and the CEO of the George Washington Medical Faculty Associates. She's also the first woman to lead the School of Medicine and Health Sciences and joined GW January 15th of 2020. So we gave her a 6-week head start before COVID hit. And I want to mention one other thing. She's a new grandmother, and that's a wonderful thing to talk about. Dean Bass?
Thank you so much, Jonathan. It's wonderful to be here. Thank you, Dean Goldman, for your kind words as well. And thank you especially to everyone who's joining us today online. I think you're going to have a great program that I think will really give you the flavor of what we have been doing here at GW over this most trying last 10 months. It's been quite a time, but I will tell you that this group has done amazing work with the abundant support, actually, of the funds that were raised in our COVID-19 response fund. Many of you contributed to that fund, raising over $170,000. And I can assure you, we've put that to good use. You're going to hear about some of that good use today. In particular, you'll hear about the amazing clinical care that our physicians, nurses, residents have provided on the front line. You're going to hear about some of the invaluable contributions that have been made on the world of vaccine development, where we are so proud to have been a site for the now imminently available Moderna vaccine. You're going to hear about the care that some of our patients have received, including some that we know hold dearly close to us for many years a bit later. And you'll hear about the response that we have had relative to the keeping our workforce safe and well during this time. As Dean Goldman said, this is really, we could call it a syndemic. We're going to focus today primarily on the COVID pandemic. But one of the big concerns we have had during this pandemic is the safety and the wellness, the mental health, the resilience, the grit, hence the title, Gratitude and Grit, that our teams across all of our partnerships, from public health and medicine and nursing and health sciences, the whole group have just been remarkably resilient. But I will confess, I'm worried about everyone. You know, I think we cannot expect everyone to have an endless reservoir of resilience. So we really are in the active stages of developing tools and programs that will support these invaluable caregivers, researchers, administrative support to let us keep forging ahead during what we know is going to be another 6 to 12 months of hard work. And so we're going to have to keep pulling together for all of that. And we're going to need to continue to make important investments in that most vital group. But today I want to let the experts who have been front and center on this, who have really been our invaluable leaders here at GW, to give you their different perspectives on their part in this remarkable last 10 months. And let me just first introduce several. I'm going to give you all of their bios first. I know them all personally well, and they are an amazing bunch of individuals. I'm so grateful for them for taking their time to be with us today. Our panelists are the following. First, Dr. David Diemert, who's a professor of medicine and microbiology, immunology, and tropical medicine at the GW School of Medicine and Health Sciences. He is our local hero for having been the clinical director. He's long served as the clinical director of the GW Vaccine Research Unit, but he's also led the team here that has been by serving as principal investigator for the Moderna vaccine trial underway at GW. As Lynn Goldman shared, he is partnering closely with Manya Magnus in the School of Public Health that has really enabled our team here to recruit the type of subjects in the trial that we really need to persuade our public that this is a good and safe and appropriate thing to do. Second, we have Dr. Amanda Castell, who's a physician and a professor in the Department of Epidemiology at the Milken Institute School of Public Health. She's also a board-certified pediatrician. She has expertise in infectious diseases and outbreak investigations and is a recognized expert in HIV surveillance and the HIV care continuum. Her expertise with disease surveillance has been instrumental in informing GW's tracking on campus, something that has really been a great benefit to our university and across the DC metro region during this last 9 months. We're also joined by one of our frontline healthcare providers who I suspect has probably treated hundreds of patients with COVID in our George Washington University Hospital. That is Dr. Juan Reyes. He's an assistant professor of medicine in George Washington University School of Medicine and Health Sciences, and he's the division director of hospitalist medicine, those physicians that take care of hospital patients that are hospitalized for intense care. He is our lead hospitalist, and over this last 9 months, we've seen incredible changes in our approaches to these patients, which he's going to articulate some of those advances, because it really has the science and the evidentiary learning that has been manifest over this 9 months is nothing short of astonishing. So Dr. Reyes will share some of those perspectives with us. He also, of course, has worked closely with our residents and even our students who are back with us now, resuming that important mission of education as well. Dr. Bill Borden also joins us. Dr. Borden is professor of medicine and health policy at the George Washington University, and he's also our chief quality and population health officer at the George Washington Medical Faculty Associates. That's where our clinical faculty practice. He specializes in preventive cardiology, the treatment of complex cholesterol disorders, and diagnosing and treating general cardiovascular diseases. I can also tell you he is always the voice of calm and reason, even in the face of extraordinarily dynamic and changing times. He has led our response initiatives to optimize care strategies and to ensure the safety of our healthcare teams. And last but not least, of course, is someone who has too much experience with COVID, having been one of the early patients to have been treated for COVID here at George Washington University Hospital. And I can assure you, he gave us all some tense weeks while he was with us in our hospital. That would be Mr. Mark Albert, who is also a double alum of GW, a graduate of Columbia College, as well as the law school. And he currently is a partner at Stinson, the Stinson law firm specializing in bankruptcy and creditor and debtor rights. He also serves on our GW MFA board and has agreed to be part of our program today to share his experience in those early days as a patient who received care at GW. So I think maybe the way that so thank you all for being here. And I hope we're going to try and keep this concise so that afterwards we will have time for some questions from the audience. So think about are we going to chat those? I think we're going to chat those in, and Jackie will, Wood or Jonathan, I believe, will add those to our discussion, presuming we have time to do so. But let's get to the meat of this, because it's really going to be exciting, I think, to learn what all these wonderful individuals have been doing. Let me start with this. Let me start with Dr. Deemer, because we are all so excited by the prospect of actually having an effective vaccine be ready for distribution in the not too far off future. And I guess, could you tell us, really, what have you learned so far in this trial? And more importantly, what can you tell us about a timeline of getting this to our people?
Nothing like getting put on the spot. Thank you, Dean Bass. Well, first of all, I think I would just say that how much of an honor it's been to be working on this trial here at GW. And has been mentioned already, it's really been a huge collaborative effort over the past 5 months or so. Working with Dr. Magnus at the School of Public Health, Dr. Mark Siegel, and the other infectious disease faculty at MFA. It's really been a big collaboration between the School of Medicine and Health Sciences, School of Public Health, and the MFA. We served as one, or are serving as one of about 100 sites for the phase 3 trial of the Moderna mRNA vaccine throughout the country. That enrolled just over 30,000 participants. We here at GW enrolled 349. We especially tried to enroll a very representative for DC and diverse population in our volunteers, and we were very successful in that. Over 50% of our study participants are people of color, African American and Hispanic Latino. So we're very encouraged that the results that will come out of the trial will be applicable to all populations. So maybe I'll say a few words on the results that have just come out in the press and elsewhere in the past couple of days. So the first interim analysis was run on Sunday, was presented to the Data and Safety Monitoring Board for the study, which I should say is a panel put together by the NIH, an independent panel of experts and statisticians. And they looked at the first 95 cases that were of COVID, symptomatic COVID, that were diagnosed in the 30,000 or so people that are in the study, starting 2 weeks after the second dose. This is a 2-dose schedule, so given 1 month apart. So there's already, even though the first vaccination was given, the end of July, there's already been 95 cases after the second dose was been given. And I have to say, we're still finishing off our vaccination. So it's pretty amazing how many cases there already have been. Of those 95 cases, 90 of them were in the placebo group and 5 of them were in the vaccine group. And it's a 50-50 split between randomization between the vaccine versus the placebo. So that results in a point efficacy, as they call it, of 94.5%. And then when you look actually at the breakdown of by age, by race, ethnicity, and also by whether or not people had coexisting medical problems, comorbidities, that efficacy actually was maintained across all of those different. So over the age of 65, it was kind of the same, around 95% efficacy. So that's very encouraging. And I think the most encouraging thing that I would say is that there were 11 cases of severe COVID that were diagnosed, and all 11 of those cases were in the placebo group. So there were none in the vaccine group. The one caveat I would say is these are early results. There's only a couple of months of follow-up that this is being based on. So we have to ensure that this efficacy lasts.
Well, thank you. That's really great information for us to have. Exciting times. We can't wait for the future news and of course for the distribution. And I might add actually that some of the funds that we received from the COVID investment, COVID donations, initially helped us set up a trailer that subsequently became the home for the COVID vaccination program. So along the way, all of our contributions have been used very directly, both to support the research initiatives, to support the clinical care teams, and also for outreach in our community as well, including most recently helping to support the distribution of 12,000 flu shots through our city. So it's really been fabulous to have that money well used. Let me next bring on Dr. Amanda Castell, because she's got a long record of scholarship and advocacy in the area of health disparities. And if this COVID pandemic has not made that disparity obvious to the entire world, nothing can, as far as I can tell. So hopefully we have learned. This has been a real stark reminder of the discrepancies that exist, disparities that exist in our society. And here in DC, we, as you know, are a divided city in regards to how we live. So I think it's really important that we keep a bright light on that. Dr. Castell, one of the next steps, of course, is going to be the distribution of this vaccination. And how are we going to make sure that we do that in an equitable and appropriate fashion to serve the needs of our community?
Yeah, thank you, Dean Bass and Dean Goldman, for inviting me to be a part of this panel and this presentation. So, as you mentioned, the pandemic really has reminded us of very long-standing health inequities and health disparities and the role of institutionalized racism in our society, from the start of the founding of our country and the treatment of Native Americans to more recent experiences such as the Tuskegee syphilis experiment, where hundreds of Black men were untreated for syphilis for decades, despite there being a treatment available. They were not able to get it. So when we started to see the data come out about COVID-19 and the racial ethnic disparities and the disproportionate impact, for those of us in the field, this really wasn't surprising. It was a reminder of where we have been, again, for centuries. You look at the data, we knew that we started to see that racial and ethnic minorities were more likely to be infected, more likely to be hospitalized, and up to 3.5 times more likely to die from COVID compared to their white counterparts. And if you delve even further into why this is, it's because of these social determinants of health, right? We know that these individuals, these populations and communities of color are more likely to have these comorbid conditions that predispose someone to having a more severe course of COVID, whether it's diabetes, obesity, hypertension. We know that there are socioeconomic factors that affect this, such as housing and living in crowded or multi-generational households, which don't allow for people to be able to socially distance. A lot of people have talked about the idea of social distancing being a privilege. How can you do that when you're living in a home where you maybe have one bedroom and one bathroom for multiple individuals? We also know that these racial ethnic minorities are disproportionately these essential frontline workers that have been really at the forefront of keeping our economy going during this time period. And yet they're putting themselves out there and they're at risk and vulnerable, and unfortunately sometimes taking the virus back to their homes and their communities. And then last but not least, also we know that there have been longstanding inequities in healthcare access and treatment that disproportionately impacts people of color. So you put all of that together and think about, okay, we have these great vaccines that may become available to us, and how do we ensure this fair and equitable distribution? I think we have to remember also that in our country that we really don't have very high vaccination rates. If you look at the vaccination rates from last year for flu, for example, only 48% of the US population was vaccinated for the flu, and even lower proportions of individuals who are, racial ethnic minorities. And we're seeing the same trends in vaccine hesitancy with COVID-19, right? If you look at recent data from Pew, they've shown that between May and September, that vaccine confidence has declined over time. We see that less than 40% of African Americans and about 50% of Hispanics are willing to consider getting a COVID vaccine. And so again, when you put that in the context of how we are able to think about equitably distributing the vaccine, we have to think about all of these different factors. The National Academies of Science has put together a great framework on the equitable distribution, and they have several kind of core tenets that include equity, justice, fairness, and using evidence-based approaches. And I think that sets a great framework for us to do this work, but we also need to think about how do we engage community leaders, right? In my work with HIV, we've done this before. We identify those key opinion leaders. We identify those social influencers now because social media is so pervasive. And we need to have those individuals at the table with us, with the drug companies, with the health departments, with the federal government, with the COVID-19 task force, to really think through what are the most important factors that people need to know about. How do we increase health literacy? How do we answer questions about how the vaccine was developed, why they need to get it, how they can protect themselves, the timeline, right? We want to set reasonable expectations. So those are some of the factors that we need to consider as well. I think my only two other points right now would be that we also need to take the politics out of this, right? We know that this is a scientific endeavor, and we need this to remain a scientific endeavor and not a political endeavor. Because it would be a tragedy if, after all of the work that people have done for these vaccines, that we don't have the confidence in our communities to actually uptake the vaccine, and it really would be a lost opportunity.
Thank you very much. It really is just a daunting but deliverable set of challenges. I think we can get there, but obviously it takes more than science. It takes a lot of trust and outreach and community building and all across the boards, and especially in face of the historical and very real ongoing challenges we have relative to structural inequity and racism. So thank you for that incredible work. We look forward to working with you on that. Next, we have Dr. Juan Reyes, who I failed to mention is also a double, a triple or something, a GW graduate, medical school, and then trained here, and also a degree in public health from the Milken Institute School of Public Health. So he's been with us a long time and has really been here as well on the forefront. So, Dr. Reyes, let's hear from you about how things have changed in terms of how we treat COVID patients now compared to when this first crashed upon us back in March. What have we learned, and what are our new tools and techniques that we're able to utilize today to make for better outcomes for these patients?
Absolutely. Thanks, Dean Bass, for having me, and hello to everyone. So, things now are very much different than how we started, and not only how we started, but also even the pre-COVID era not too long ago. Not only did we have to learn about the therapeutics or lack thereof at that time, but also we had to transform the workflow that happened in our inpatient setting, in large part because of the number of patients that we started seeing in April and March, where we had basically get to the point where we had to risk stratify patients who needed to go to the unit versus patients who needed to stay on the floor. And in order to do that, we had to actually establish some protocols and procedures that were usually reserved for the intensive care unit setting to be brought on the floor. So it was an immense effort across not only our hospitalist colleagues, but also with the ICU, our nurses, our residents, a huge collaboration in trying to bring in some of these interventions from the unit out to the floor. So we reserve those most important beds with regards to vented patients and ECMOs for the ICU. Certainly the beginning was very challenging, as probably most of us know, or a lot of you know. There wasn't much obviously known about this virus and how to treat it, how to manage it. A lot of it was coming out of, interestingly, the press as opposed to studies that anyone had at that time. And so we had to organize ourselves very quickly into what we call different work groups. And it was pretty much a hospitalist-led initiative in our group, where each hospitalist became in charge of pretty much knowing everything they needed to know about the therapeutics, about interventions, about safety and quality, to bring back to the group and debrief almost on a daily basis. And we had a daily huddle around 2 p.m. every day from where we debriefed, and in collaboration also with our colleagues with cardiology, pulmonary, ICU, physical therapy, nursing, and also our resident leadership, who are very much also on the front lines with us as well. We established our norms and guidelines as to how to take care of these patients, which pretty much at the beginning also changed in pretty much on a daily basis. But out of this work between everyone, it came out the backbone of how we're usually trying to manage these patients on the wards, which is now fairly, hopefully, aggressive up front. It was very disheartening at the beginning since we didn't have many tools at our disposal, and a lot of these medications were reserved for the sickest. A lot of it was watch and wait from our end, but that quickly transformed into bringing some of the interventions that were helping in the ICU, like proning. We called it tummy time on the floor. So we had we certainly had a push to try and get some of these patients onto their belly. Certainly at this stage of the course, some of the therapeutics that have become a little bit standard of care for our patients is remdesivir, as everyone has heard about, depending on obviously the clinical presentation and needs. But certainly due to the recovery trial also, steroids has become a staple of some of our patients who are severely ill. And obviously trying to avoid the intubation, which is very important as well. This is a big role that we've taken over in the hospital with the use of high flow oxygen delivery methods to try and keep these patients as much as possible and preventing them from being intubated. So, a lot of this work, obviously I'm here, but it's a reflection of countless number of people and hours of our colleagues, not only on the Division of Hospital Medicine, but across the board with the ICU, nursing, and by all means, our residents who have been in the front line as well, which despite that, we've also had the luxury of having both the clerkship director and acting intern director to develop ways into incorporating telehealth or telemedicine, if you want to look at it that way, into the education as well of our residents and students.
Yeah, thank you so much. Yeah, no, it's really been just a remarkable transformation and adoption, rapid translation of published work into practice. It's been very exciting. And I might add actually that during the early days, when all the restaurants shut down and everything, one of the things that this COVID response fund was really helpful for was making sure we had lunch for everybody and meals for people, because restaurants weren't readily available. It was important, and housing for our residents and faculty who didn't feel safe going home, having worked in the COVID hospital environment. It was really valuable and a remarkable team process. And so I think we are really grateful for all that you've done during that period of time. And that said, we've actually managed to keep our faculty, our students, our residents safe. Our rates of infection are well below that in the community, which means that we have learned very effectively that PPE, used appropriately and well and readily available as ours was, courtesy in the very early days, in some respects, to the COVID response fund, that we've been able to keep people safe. So thank you very much for your leadership during that time and for the advances you've shared with us today. I want to move on to Dr. Bill Borden, who I know can tell us about all kinds of things, but we're going to ask him about what lessons you've learned during this last 9 months as healthcare practitioners that you think are going to really have a lasting application in terms of how we approach our work as physicians. Could you tell us about that, Dr. Borden?
Absolutely. Well, thank you, Dean Bass, for having me, and thank you, everyone, for joining this session today. So there's a ton that we've learned, for better or for worse, and I'm just going to talk about a couple of key lessons. And the first one is sort of around our healthcare workforce wellness and safety. I mean, I remember back in the spring being in the hospital on service, and, in the morning, as we were gearing up to go see patients who had COVID-19, and seeing just the remarkable determination and professionalism of the residents that I was working with. These are people who are, 1, 2, 3 years out of medical school. And, they, you could see they're scared behind their eyes, but they knew that this is what they had to do and that they had chosen this profession to help people and care for people. They trusted in the PPE that they had, and they did what they had to do. And it was one of the moments my entire career when I've been most proud of my colleagues and the nurses that we work with, and really remarkable. And so I think, we've always known this, that the healthcare workforce safety and wellness is important, but I think we're, increasingly recognizing that importance. So, a lot of it's the PPE, and I've never been so grateful for things like masks, surgical masks, and N95s, which have taken for granted over our careers, and how important that is. But then also just really the importance of taking care of ourselves. We have an incredibly strong, resilient healthcare workforce, but we're not indestructible. And I think for many years we've kind of been trained and have taken on ourselves that we are indestructible, that we don't need to sleep, we don't need to eat, we can, if we've got a cold, we can come to work. And I think that, that's changed. And as we go forward, that is going to change. And that, taking care of ourselves in terms of our physical wellness, staying home when we're sick, even, wearing masks, wearing masks, if someone had the sniffles used to be sort of taboo. And I think that we're going to see that more and more going forward. But equally important is our own sort of mental and emotional wellness. This is incredibly trying. It's difficult. We all have families at home, friends, loved ones. We worry about ourselves. We worry about them. And so that's where we've put into place a lot of programs, and Dean Bass has taken a tremendous leadership role in this around supporting our healthcare workers. And, the community has been tremendously helpful. Dean Bass mentioned the meals that came in the springtime, and other gifts and the signs and other, expressions of support were so appreciated. But we have to look at this as something that is sustainable going forward. And what are those programs, including mental health services, that our healthcare workforce needs to stay healthy? So I think the second thing going forward that's going to be a big part of medicine is telehealth. So, I did my very first telehealth visit this springtime, and I wasn't very good at it. That first one, I have to say, it was kind of awkward with the screens. And, I was used to being able to walk in and shake someone's hand. But I learned, and we've all learned. And I think that telehealth has been sort of a solution that's been waiting to break loose, and it has in a big way. And it's been great for our patients. It's been great for our providers, in that it gives access in a safe way. And there are a lot of conditions that can be managed through telehealth. Now, it's not a solution for every patient, and it's not a solution for every situation. As Dean Bass mentioned, I'm a preventive cardiologist, and I'll tell you, for a lot of my visits, it's great. It gives us more time to talk through preventive measures. But, if someone's coming in and, they're having shortness of breath or abdominal pain, they need a physical exam. And so it may not be the perfect solution there. I think that we also have to look at, making sure that everyone has access to this important technology. And then we're not worsening healthcare disparities and people who don't have access to the technology or internet access. And there's been a lot of research published in this area. And then lastly, in telehealth, we have to make sure that we understand the quality measures and the right situations and how to perform telehealth safely. And just to mention one example, one of our physicians was on a telehealth visit, and unfortunately the patient lost consciousness. And that physician had followed the safety measures, and that they knew where the patient was, were able to activate EMS, call 911. The patient was brought to the hospital and fortunately has done well. And so it's an example, as we're learning with this new technology, how to do it safely and ensure the highest quality of care. So I think the last thing I would just mention in terms of going forward is there's tremendous innovation that's happening. This is sort of an unfreezing of our healthcare environment. And it's an opportunity to do new and exciting things and see what works. Maybe some things won't. And there are going to be things that we're going to be able to carry forward. So we talked about telehealth. There's been a lot of work, and our emergency medicine department has been leading work around home monitoring devices for oxygen and heart rate as well. I think we've also learned that healthcare doesn't need to stay within the confines of the brick and mortar buildings. We've launched a COVID testing clinic. It was initially a tent. Now it's in one of the university dining halls. although we still call it lovingly the tent, even though it's not a tent anymore. We set up drive-through testing. We've arranged house calls. And I think that one of the things that we've really done, again, through our emergency medicine group, that has played a tremendous role in our DC community is that we've set up what we call strike teams that have gone out and done testing in nursing homes throughout the DC area, in prisons. Those sort of facilities are places where COVID has really spread and could be incredibly deadly. And so our ability to be able to put together teams that can go and safely do COVID testing has been invaluable for our broader community in terms of controlling this pandemic. So I'll stop there, and thank you again for this opportunity to talk with you all.
Well, thank you very much, Dr. Borden. Great observations and great plans for the future. So let's move on to our final panelist, Mr. Mark Albert, who was one of our early, very ill patients. And I just wondered if you would, I know you've spoken to us about this in the past, and I wonder if you'd be able to share your experience with us and just to let our interested community know.
Of course, Doctor, and thank you for including me today. It was indeed March 2020. It happened, or perhaps I was just in denial. I had my youth off. I seemed to be working harder than usual. I had some tough trials that I needed to try. We were closing our law firm due to the pandemic and needed to coordinate bringing stuff home. At 71, I continued to keep the schedule, keep routine. On the Saturday day of my sickness, I went to boxing class, the office for 6 hours of work, and my husband and I hosted our best friends for dinner. In the middle of dinner, extraordinarily tired, and went to bed earlier than usual, about 9 p.m. And went to bed, and my journey indeed began. Sleeping, delirium, coughing, and not breathing, saying I was going to die. It seemed like, I think, for about days. My husband kept taking my temperature and oxygen levels. I was pretty much unconscious. Although I do remember one day when Stephen said we were going to go take a walk to the MFA, and I was going to be tested. Indeed, we walked. We had no car, and we didn't want to be in a vehicle and endanger others. In fact, we walked home as well, about a mile, all with a temperature and a cough. Turned out I was positive. I went back to bed and stayed basically unconscious. Finally, Stephen said one day, we're going to the hospital. My oxygen level was in the 70s at that point. And he called an ambulance. They wouldn't come into the house due to the fact Stephen told them I had COVID. He had to carry me to the ambulance. I delayed my going to the ambulance because I insisted on paying the bills for 3 months first. As Stephen, GW, and the ambulance folks had to negotiate that I wanted to go to GW to take me elsewhere. About 3 hours later, I arrived at GW to a team of friendly GW medical folks and a girl. I really was sick. They took me to the ICU, and it in fact looked pretty good to me. I think I had a nice view. Not much memory of the time at the hospital, at the ICU. I was told that I insisted on calling Stephen on his birthday, but that was pretty much my memory. I had lots of problems. Eventually, I was put on a ventilator and placed in an induced coma. This was pretty much a new time for the disease, and folks really didn't know that much about how to treat the disease and treat me. I was told that I was dying, my kidneys were failing, and the medicines they gave me were working. However, GW, the medical school, the hospital, and my friends, family, who included many critical care doctors also, they worked together, and they worked to keep trying new medicines to keep me alive until my own body could take over. They tried to get me off the ventilator unsuccessfully a couple times. Apparently, I took perhaps too much morphine in my body. But one day they were sick and I started to breathe after I think about 13 days and come out of the coma. My first remembrance was saying, I want to go home. I need to go to work. Guess that makes sense. I was in a hospital for a month. Unfortunately, I was like a baby. I couldn't walk, crawl, or stand. 1 month in the hospital, strapped into a bed and on a ventilator for 13 days, took a toll on my body. We started at GW with a physical therapist who was just wonderful, but it was only for maybe an hour a day, very slow going. I was in complete isolation. Even my cell phone disappeared, and my impaired brain was not helping me dial a phone. No one could come see me. The medical staff rightfully were very cautious given the infectious disease I had. I was very much alone. I insisted on going home. I was told that wasn't a good idea. I finally called my friend Kim, who heads the hospital, and told her, thank you, you helped save my life, but it was time to go home. She was concerned. She said I would not get help I needed at home given my COVID. I said I promised her I would. Indeed, I went home and I got help at my house for 6 weeks. I am a true outlier. My doctors tell me there is nothing now wrong with me. And in fact, I am back. Lessons. New disease, no one really knew what to do. Very lonely and isolating disease. Great team. Thank you, GW. Working together between or among GW, my family and friends saved my life. I think my own courage and strength helped me live as well. Finally, don't give up on a person depending on his or her age. It's a terrible disease, but remember it's a virus and you can recover as I did completely. Thank you.
Thank you very much, Mark. It's probably the purest expression of gratitude and grit that I've heard. So that was really, really, really amazing what you did. But and you really were one of the really early people who became critically ill in our hospital. And it is astonishing to look at how care has transformed since that time. But we're all thrilled the day you finally did go home, and then to see you actually resume full health has really just been fabulous, because that doesn't always happen either. We still have to learn about that part of the disease, you know? So I think there's this one great movie. I love this thing. I shouldn't say it, but I won't say it really. But there's a movie called Martian. Remember the one where Matt Damon goes to Mars and gets stuck on the moon on Mars, and everything blows up, and he's there with like some potatoes or something and a few little nets, and his line is, "We're going to blip out of this." And the idea is that is what we have done with this disease. We have, we're going to science the blip out of this. That's what we're going to do with this disease. And that's what we've done with this disease. We have scienced the blip out of this disease. If you think of how much we have learned in these last 9 months, how much discovery science, how much translational science, how much applied science, how much public health dissemination science, it's just astonishing how far. And of course, the culminating of this will be the vaccination. I mean, in really 9 months, 10 months, it's astonishing. And I think for all of us, it's actually part of our resilience boost that we get out of this is realizing that we have come such a long way so quickly. It makes you feel proud to be in healthcare right now. It makes you feel proud to be part of this GW community that has contributed in every single one of those areas of discovery, translation, application, wellness, caring for others. It's astonishing. So I think we should this whole group should be really proud, and I know I'm very proud of the work that our community has done during this time, and really honored to be part of it. And the people like Mark are the reason we do it, right? That's why we do it. It's those people that otherwise would not be with us today in this panel. And the many, many others who we hope we will be able to prevent from ever having this disease, and who we continue to support during this time of escalating rates. Fortunately, we haven't quite seen that bump yet here at GW University Hospital, but we are prepared for it because we do believe that this is going to get worse before it gets better. But I think that this has been just a wonderful panel. I really appreciate the contributions. I hope it's been informative to our participants at home as well. So, Jonathan, can you help me here? Do we have questions to do? Do we have more discussion? How are we going to do this now?
We've got some questions from the audience, and the first one comes in. Let's talk about sciencing the blank out of this. Can you explain for the lay audience the mRNA vaccine structure and why it's so different from previous vaccines? We've been hearing a lot about, I believe Pfizer and Moderna are both mRNA, if I'm correct on that. What does it actually mean to our lay audience? Why don't we start with David Deemer, Dr. Deemer?
Yeah,
Sure.
Dr. Deemer for that one.
I'll take a crack at it. So, yes, you're right. So, both the Pfizer and the Moderna vaccines are based on mRNA or messenger RNA. So, just for people who don't have a science background, what that means is RNA is a nucleic acid. So, it's basically what cells use to make protein. So, what you're basically doing is you're giving a piece of code, genetic code, to someone, and that gets taken up by their cells, mostly their muscle cells and other cells where you inject the vaccine. And then it kind of tricks your own cells to produce the protein. And this particular protein that's being produced is one of the SARS-CoV-2 virus proteins that's found on the surface of the virus, and we think is very important for the virus to be able to attach to and get into our own cells. So the idea is then, once that protein is made by our cells, then our immune system realizes, like, wait a second, it's not supposed to be here. The immune system kicks into gear and makes all kinds of antibodies against that virus protein. And then those antibodies will stick around and protect people, hopefully, and it looks like it's true based on the results we saw this week, will protect people when they come into contact with the virus from getting sick.
That's great. Thank you very much, Dr. Deemer. We have another question that just came in. What will vaccine development look like going forward post-Operation Warp Speed? And I know as we've looked in history at vaccine development, it's taken years and sometimes decades. Do we feel like that we've learned something in the last 9 months and that this could actually speed up future vaccine development? And I'll lean on whoever might have the best response to that. Maybe Dr. Castell.
Yeah, that's a great question. This is an example, as you said, of where innovation has really allowed us to move quickly in our response and to be able to get viable vaccine candidates, hopefully out there relatively quickly. In terms of the COVID vaccines, I would anticipate that, because we already have, or the federal government has contracts with companies to produce the vaccine, that first phase, the first high priority group of people, including healthcare workers, first responders, should be able to get access to the vaccine, hopefully by early 2021. And then we'll phase out from there. There are about three other phases that need to be met until we can get the vaccine to the broader community.
Thank you very much. So we have a lot of questions coming in. How do you plan to build community confidence in this vaccine, especially in the hardest hit areas? And again, you talked about it earlier, Dr. Castell, about the real difference between how certain people will eagerly get this vaccine and how some are very skeptical about this. Do our physicians have a thought in terms of how we really build confidence? And is it, quite frankly, just socializing everybody to the idea and making sure that the facts are out there?
Maybe Dr. Deemer should take that one, you think, or Dr. Castell? Both of you chime in on that one, huh?
Maybe I'll start, but I think definitely Dr. Castell should add to whatever I say because she has more experience in this area. But I would say, I mean, that is exactly one of the main reasons that we were so careful to enroll and encourage participation from a diverse community, into the clinical trial that we did here at GW. Because those, and we found that even early, the kind of first people who enrolled in our study, they served as ambassadors to the broader community and encouraged other people to volunteer and to participate in the study. I think that having those representatives who are in the trial here at GW could serve almost like ambassadors for the broader community, and that's who people are going to trust more so than, say, me or the other people on this panel. I think that's why we work so hard to get a very representative group of people that participated in the study here.
Yeah, I don't have much add to what Dr. Demert said. I do think that it has to be the trusted voices in the community, and certainly hearing from people who participated in the vaccine trials is extremely important. But also hearing from people who are survivors, as we have, who've survived COVID, and understanding, how severe this illness can be, so that it's not something that people, think, well, it's not going to happen to me. I don't necessarily need this vaccine. Why, we really have to make them understand what the risk factors are and why it's important that they avail themselves of this vaccine.
It's been interesting.
So the next question comes in for.
I was going to say, we had the good fortune, actually, of having one of our leaders in this District of Columbia, Wayne Turnage, who is the vice mayor of he's top in command, basically, along with Dr. LaQuandra Nesbitt. He's an administrative of the health organization in the district, and he was a participant in the trial, and did a fabulous job of outreach to the community thereafter. Sort of pointing out he's an African American man, that he has health risks that would make him at high risk for disease, and then really being a wonderful advocate to the community to try and build that important confidence. So we're grateful to Wayne Turnage for his visible participation in the trial.
So the next question is for our wonderful patient and the great story that you told, Mark, to the group. And the question is, do you have any lasting side effects now that you've recovered from this? Tell us how you're feeling today.
I feel terrific today. I have no side effects. I have no lingering illness, and I am back full time. I'm back to being with my trainers 3 times a week, including boxing, tennis, and other weight training exercises. Thank you for asking. I was a lucky, though, indeed.
That's wonderful to hear. So the next question comes in to the folks that were treating patients on the front line. And the question is, do you think COVID is prone to attack people who are run down, people who are working hard, long hours, that kind of thing? Have you seen anything in the data right now that's showing people who were stressed or fatigued might be more susceptible to COVID?
Sure, I think I can jump in on this one. So nothing in the data to suggest that if you're more run down, you're more likely. I think what the data is showing that obviously with COVID, everyone was pretty much stressed out and run down. And to be honest, I think the biggest challenge has been the unpredictability of the disease. Certainly, a lot of the news media and a lot of the information that's put out there talks about the being a disease potentially more of the elderly, and what we see unfortunately in the hospitalized setting is, while we do see certainly a number of patients that may be older, we're seeing the spectrum of ages, of ethnicities, of gender, and even in patients who don't necessarily have all these comorbidities that we think about as risk factors, progressing to a state of the illness that is extremely unexpected, and the rapidity in which they decompensate is certainly something that's been very alarming for us and disconcerting. To that end, here at GW, we focused on a couple of things. We've certainly have looked into trying to see if we can find biomarkers that could be a signal for us to try and find out which patients may deteriorate before it actually happens, which could be helpful in risk stratifying these patients while they're here. And also in taking advantage of the skill set of some of our colleagues, and one of them in data science and bioinformatics, establishing and doing the building blocks of developing and bringing in a little bit of bioinformatics and artificial intelligence to some of these experiences that we're having, because it's exceedingly hard to get reliable information so quickly, especially for something so novel, with regards with what to do from a therapeutic standpoint and interventions. And so we're looking at to see if we can start incorporating a little bit of the artificial intelligence piece and looking at our patients in-house, because the disease behaves very unpredictably as to anything that we're usually accustomed to treating in the in-house.
Thank you very much, Dr. Reyes. The next question is for Dr. Borden, and we're hearing a lot about, in fact, college football players who have tested positive for COVID and are having some lasting heart effects. Is there any data on that you can talk about, and is that something that we hope will get better over time, or is this something that these young people are going to be living with for the rest of their lives?
Yeah, thank you. It's an excellent question. And, we recognized pretty early on in the pandemic that there were pretty significant cardiac or heart effects of COVID-19, that it causes what's called a cardiomyopathy, a weakening of the heart, and the heart can grow in size. And that can present all kinds of other complications like abnormal heart rhythms, fluid overload, and it can be a cause for death. A lot of times this was temporary and during the period of acute illness, but we've also seen that this has lingered on for periods of time, extending well beyond the recovery from the infection, sometimes recovering, but there may be longer lasting effects. And we're also seeing that sometimes in younger people, that there are these cardiac effects when people otherwise were not sort of acutely ill. So there's a tremendous amount of work in this space looking at this. In fact, one of our cardiologists here, Dr. Andrew Choi, has been doing a lot of work in this space and has been active nationally in professional organizations looking at guidance around imaging of the heart in patients with COVID-19. So an active area of focus, both clinically and in research.
That's wonderful. The next question comes in. I'm going to use her name. The next question comes in from Hannah. I'm going to use her name, Dr. Bass, because she's applying to GW Medical School. She is the daughter of two alums of GW, and she's currently a researcher on Operation Warp Speed working on a vaccine. So Hannah, wonderful. Thank you for that. And her question is, what sorts of difficult medical choices must a physician make when there is no known cure to an illness like this? And so I guess that's again for Drs. Reyes and Borden, who are on the front lines of this. What were you doing early on when you were kind of trying to figure this out?
Great, thanks for the question. Absolutely. At the beginning, I alluded to this at the beginning when I started speaking, is that it was very disheartening to see our patients initially who were on the floor where we were providing supportive care, watching them either get better or get worse and end up in the intensive care unit. And as a response to that, we felt an obligation to see what we could do up front to try and either intervene earlier, to see if there could be an impact to either preventing progression of the intensive care unit, preventing intubation, if not, at the end of the day, improve survival. At the end of the day, they required a huge amount of effort from everyone involved across several disciplines to basically digest all the information that was coming out at that time, to try and bring it back to the group and develop a specific set of guidelines that pretty much changed on a daily basis. It was certainly conversations with patients, and very challenging conversations with patients when it came to also misinformation that was out there in the news as well, and trying to help them understand that maybe one medication, classically, I remember hydroxychloroquine and azithromycin. Those were very difficult conversations to have when people were expecting these medications to be given. but we had looked into some of it already, and it was actually causing potentially more harm than benefit. Having said that, though, on the other end, and for those who have been patients, like we have in our panel today, the patients have been, exceedingly open and receptive to the fact that this is an ever-changing process. This, during, especially in the early times, almost a daily change where we would say one thing today and another thing the latter. Especially in circumstances where they're very isolated, the partnership with the patients, I think that we had, even though it's isolating, was probably more significant for us because it did require, to a certain extent, an individualized care approach. That's why, to a certain extent, we have, I guess, again, I mentioned this, taking advantage of some of the skill sets of our colleagues. Randomized trials obviously are happening, and it's the gold standard. But I do think that taking advantage of the skill set of bioinformatics and bringing in artificial intelligence potentially in the future and some of the clinical decision making that can happen in the hospital setting to provide more real-time solutions is where we're at. And it did help us out, for example, with the conundrum of anticoagulation when we hear about these patients developing clots. While a lot of the information that was coming out in May is all these patients needed to be in blood thinners, we did partner with a hospital to actually do a patient safety analysis on the patients that we had on anticoagulation. And it was very clear that it is very nuanced. Not everybody can benefit from it. Certainly the most critically ill patients are the ones probably carrying the burden of disease when it comes to these clots. And there's different types of clots that we're seeing. But we were able to adjust our practice probably back in May and not providing a blanket treatment for every patient with undue risk at that time, with increased risk of bleeding. So it's challenging. It is an ongoing challenge. We continue to work on our work groups and developing our database to be able to go back and analyze what our progress has been, what our patient safety profile has been on these interventions, and keep adjusting the therapeutics and the interventions that we're doing in-house.
Thank you, Dr. Reyes. And we have time, I think, for two more questions. Go ahead, Dean Bass.
Just for a second to Hannah, especially getting ready to begin her medical education journey. One of the things that we learn in medicine is we don't always have answers, no matter what you think you've learned along the way. And medicine is, in many respects, a lifelong experiential learning journey. And we continuously observe and use every tool in our toolbox when we come to these new unknowns. And it's actually one of the things that makes medicine an exciting and very living profession. But I do think that one of the things that this whole experience here has highlighted, though, is the unique space that academic medical centers play in the response to new diseases like COVID. As you've heard today, we can bring to the table the incredible expertise of scientists, of clinicians who are skilled in the science of clinical trials. It's not everybody can do a clinical trial. It's kind of hard, actually. Not everybody can partner with epidemiologists and public health experts. So that is the beauty of what an academic medical center can do. And if we look at this experience nationwide relative to the COVID experience, I think, thankfully, the public has learned a lot about the unique and critically important space that academic medicine plays in our communities in response, especially to these challenging new diseases as they evolve. And they will continue to evolve. They will continue. That's our space, though. That's our really sheer bliss point. So we hope that when you do get into medicine, you'll think about that as part of your future as well.
So our final question, and we have a couple more minutes left. Our final question, we have a lot of questions. I'm picking this one out in particular because we haven't spoken about children and adolescents with regards to COVID in our talk today. And one of the questions that came in was, will children be inoculated similar to how they are now for a host of diseases going forward, assuming that these vaccines are good? And I'll throw that out to whoever is the best expert for that, probably Dr. Castell, I would think.
Yeah, that's true. I'll find out.
Yeah, I was actually going to defer to Dr. Demir, but I know that there are some trials that are starting to look at children under the age of 18 to see if the vaccines are effective and safe in those populations. As a pediatrician, one of the hardest parts for these trials for us is that the studies have to be done in adults first before and proven to be safe and efficacious before they go into the pediatric population. So I would envision that now that we do have evidence of a signal of effectiveness in the adult population, that then we will start to scale up these studies in the pediatric population. But I don't know if Dr. Demerit has more to add to that.
Yeah, sure. So I can say that there are definite plans. There's even been protocols written for doing pediatric studies, including all the way through phase 3 or efficacy trials. Although we're very hopeful that with the app, be able to establish what we call a correlative protection, like say looking at the antibody level in the blood and see if that predicts whether or not someone is going to be protected or not. And then so we can do much smaller studies in kids, even all the way down into infancy, just looking at antibody responses without having to do massive trials like we're doing currently for adults. So that's hopefully something that will come out from the adult studies that will inform the pediatric trials. But those plans are definitely well underway.
Well, thank you very much for that answer. I'm going to try to squeeze in one more quick question because I think it's really relevant to where we are today, and it's for Dean Bass. In your role overseeing the medical school specifically, there are medical school deans that have been graduating students early to get them into the workforce with the need for that. How do you make a decision like that? And if this really gets bad in the next 6 weeks, is that something that you would think about?
Yeah, we've had discussions about that last spring. Really, are we ready to send our precious newly minted MDs off to the front lines of COVID? There were a few schools that did so in New York, in particular, and for the most part, however, those young graduates are not quite ready to be independent doctors. They're ready to become graduates that would be part of the workforce as a residency. So most of the places where that happened, they actually went from medical school into started early in their residency training programs. I think that if we really have a total crunch and we're out of healthcare providers and our young people are game for that next step early on, as I think most of the impassioned students that we have would be, yes, we would consider that. I hope we don't get to that point, though. And in many respects, I hope that for many reasons. One is that I hope we'll be in a different place by the time this next year's graduation comes around. But also, I think that for those of you who know medical students, they're a fairly intense bunch. They work really hard. And that little window of time in between graduation and where they start that piece where they really become the doctors they're going to be as residents in medicine or surgery or pediatrics or whatever their discipline will be, that little breather there is often one of the few breathers they have in that already sort of 16-year journey they've taken to become a physician. And it's a really important time to take a deep breath. So I hope that doesn't happen. If our country needs it, we would consider that, yes.
All right. Well, I want to thank everybody, including our wonderful audience that joined us today, the wonderful panelists for their time this afternoon. It's clear that the COVID pandemic and subsequent response from our GW leadership has positioned us to come out of this even stronger than when it began. I hope everyone can enjoy a wonderful Thanksgiving next week, albeit a little bit different this year, and wish you good health and happiness. To our guests, thank you for your interest and your financial support during these incredible times. It has made a difference. Thank you, everybody. Be safe and be well.